Yeah, we can see it.
All right. 75-year-old female who came in due to a change in vision that occurred 4 weeks ago unilaterally. She thought maybe it was associated with post-cataract blurry vision. No fevers. You can see her past medical history. It's fairly benign. She had a mastectomy in the distant past with no history of Mets. Again, her meds are there, fairly benign, nothing crazy going on. But you can see marked discrepancy in her vision. She was count fingers in the right eye, 20/32 in the left, normal pressures.
Okay, so going from this photo of the right eye, focusing on mostly the macula, the media is like maybe the winkiest link of hazy, but
If you wanted to sit down here, you could, but you don't have to. Go ahead.
I'll come. Okay, so actually the media is not hazy, never mind. So the nervous pink, sharp, and flat, the vessels are normal caliber. The periphery that we can see is normal, and the macula looks like there's some drusen in there, maybe a slightly blunted foveal light reflex, but otherwise there's no hemorrhage. Looks fine.
Yeah, and Dr. Cohen, a question for you. The superior aspect of this,
Oh,
what? Go
sorry,
ahead,
I saw something else, but go ahead.
Is this just blur from the focus, or was there a little bit of haze overlying the superior fovea or superior
No.
macula?
No, I think that's just the retina.
Okay.
I don't think I think the media is pretty clear.
Okay.
Do you have an analysis?
Yeah,
Okay.
I just think- yeah, these here in the superior macula look a little funny. There might be one there too. They're like orangey ill-defined brown
Good.
lesions, is what I would call them. Left eye, so same, everything normal except for macula. There's some drusen. Is this an artifact?
It's not.
Oh.
Okay, so it looks intraretinal then, because I can see the vessel with it.
Good.
And it's larger than the ones in the fellow eye, but same ill-defined borders, and then down here, there's some pigment.
Yeah.
clumping.
And just as a reminder, she was coming in at least asymptomatic in this eye.
Yeah, weird. Okay. This looks like an autofluorescence image.
It's a IR.
Is it an IR? Thank you. Okay, so an IR image with
I think it's on a question.
I thought this one was a red free because we have a auto later on.
Because the nerve is dark and the vessels are dark.
Okay.
some hyper autofluorescence, kind of an patchy distribution with almost like scalloped hypo autofluorescent borders, it looks like. And then very early similar findings here. Maybe a little stipple up there, but
How old is the patient again? 74, mid-70s.
okay, so we have the OCT of the right eye, it looks like. So starting with the vitreous, there's maybe one cell there, a hyperreflective opacity of some sort. Otherwise, it's clear. The foveal contour is slightly attenuated. There's an ERM there. In the intraretinal layers themselves, so there's some hyperreflective material. And then in the outer retina, they're kind of like these drusen-y looking deposits. Oh, she does have drusen, so they are drusen. And then some outer retinal disruptions with a lot of shine through.
Yeah, so that the ISOS photoreceptor lighters,
Just gone.
yeah,
It's obliterated.
yeah, and consistent with her level of vision.
This is the fellow eye, so vitreous is clear. There's a little ERM. The foveal contour is also attenuated here.
And,
Oh, is
and
this?
I'm, it's, yeah.
It has a vertical
Yeah,
cut?
yeah.
Oh, okay. I was gonna say, this looks
Yeah,
just like the
Yeah,
other eye.
yeah.
Okay, so,
This is still the right eye.
I don't really see anything new on the vertical cut. Maybe the choroid looks a little weird. Like the blood vessels might be a little bit bigger in caliber, but otherwise just that diffuse ISOS junction lost throughout the drusen attenuated contour.
Now we're in the black.
Okay, so this looks much better. So clear here, no ERM. A drusen in the middle with maybe a little bit of attenuation of foveal contour, and for the most part, the outer retinal, like the ISOS junction looks fine. Maybe this was where the spot was. because it looks a little
That's the
blurry
vertical
there.
cut, the other one or something. So, yeah, you can, where was the spot?
I think this is the left eye.
Yeah,
The left eye was just infratemp to the.
yeah, you know, these might have missed it. Sometimes your cuts miss it.
But agreed, ISOS here, nice and continuous.
And then a vertical cut here showing the same. Nothing.
Yeah, this one's actually the horizontal, but.
Oh,
it-
LOL.
But
Can you remind me how the
This is the
tell?
horizontal on the left eye,
yes,
Yeah.
so that would be through it.
and so the way to tell on this one is the nerve is over towards the left. You're getting to the pericopular region.
Whereas in the last one, this was a vertical of the left.
Correct.
Oh,
Yeah,
so you don't see the nerve anywhere?
Yeah, and you see the nerve fibers symmetric. So if you look at the nerve fiber on the right, so
It
there, so
thickens.
there
Yeah.
the nerve fibers thick on the left, thin on the right, or absent on the right. And then if you go to the other one, the nerve fiber symmetric.
Okay.
So that's what's.
This is an IR photo. So it looks like there's ERM with some striations. And then there's this huge hyporeflective area in the middle, also with oh sorry, I said hyperreflective with hyporeflective border, kind of like the autofluorescent image, with some few stipples of more hyperreflectance. I think this is an infrared.
Yeah.
So,
Okay.
How can you tell it's IR compared
Well,
to?
it's not IR, but also,
Yeah, I know. but-
the vessels, you see the reflection from the arteries,
You can see
the
the
vessels look different.
lumen
In
is-
an autofluorescence, they're all dark.
Darker, okay.
Yeah, because they don't autofluoresce. And the nerves dark, although the autofluorescence sometimes. There's a lot of images, so you're doing well.
just say like hyporeflective and hyperreflective kind of patch like the other eye, but a lot smaller. So this is where we saw the lesion.
Yep.
And it's hyperreflective and then some dead stuff around it. So, okay, this is I just ICG.
Fluorescence.
Is it that way? Okay, so this is past the AV phase, so we're a little bit later in the game here. And so far, like the vessels and everything look okay. The choroid looks fine. You just have this dark hypofluorescent spot involving the macula that corresponds to the other pictures that we saw. And I would say that that is not, maybe is it not a vascular filling defect, but I don't think it's
Oh, you can't
blocking
tell, yeah.
either. Okay.
Which is dark.
And then maybe a little bit of leakage around the nerve starting and maybe a little bit here of some hypofluorescence. But yeah, leakage. I would call it leakage because the borders are fuzzy.
Classic.
Good.
So same thing here, starting a little bit later on, and then we saw as it moved through, we all had some leakage in the area where we saw the spot and some of the other weird stuff in the superior fovea. Yeah. This is the ICG. Just a hypofluorescent large spot in the choroid in the middle. The same.
It's interesting, you're actually seeing the choroidal vessels through it. So it's not really.
Oh, so it's just like thinned out retina on top of it?
It's blocking. There's recent evidence, people, this is not in the textbooks yet, I don't know why, because it's not super recent. But a lot of these syndromes, a lot of these retinal diseases, what it tries to say is the RP actively uptakes ICG. So when you see these defects on ICG, it sometimes means their RP is not able to uptake the ICG.
Okay.
So there's actually an active uptake of the RP. So we always have a choroid this, you're trying to figure out what's going on. It's probably just that you're not getting uptake of the, some of this is blockage, but some of it's you're not getting uptake of the ICG and the RP. Probably. Well, actually, some of it's probably.
So then would you say that other than those spots which may not signify pathology in the choroid, these ICGs are pretty normal?
No, what do you,
Oh,
the dark spots, yeah, there's either a capillary, might have capillary loss, or you
Yeah.
might have a lack of uptake, but yeah, there's something going, it's dark, and what you see on the ICGs is dark early, so you have an early one, and then later it's dark still.
mhm.
So you've got your fluorescein, which was dark and then light, and then this is dark and dark. Those are kind of just the overview.
Pretty similar situation.
Yeah.
Okay, so to summarize, we have severe vision loss in the right eye that's painless, just described as a blur in the floater. In a 70-something-year-old woman, who has these weird orange ill-defined lesions in both eyes. In the right eye, she has some like exudates and some outer retinal loss, and some leakage on the FA. And then similar findings, but not really involving the fovea, not nearly as extensive in the fellow eye.
Good. And then like Dr. Cohen was saying on the FA, early hypo, late hyper. I basically have the same thing. Ill-defined placoid lesions, right greater than left. You've got IR, OCT, FA, ICG. What's your differential?
I think this looks definitely different than it, but you could think about acute posterior placoid chorioretinopathy maybe.
Yep.
Serpiginous is on the differential. I don't know, some.
What do you guys
weird-
see a lot of at the VA?
Yeah,
Oh,
syphilis.
here.
Both.
Yeah.
Maybe like metastatic disease with the orange creamy lesions, but then the other stuff with outer retinal loss, I don't know if you would get that with Mets.
Yeah, lymphoma type thing.
Cool.
Syphilis is a blocker.
Yeah.
Yeah.
Just like.
So the suspicion for syphilis is high.
How old is she?
74.
She reads her. mind.
No, she got down. I don't know.
She does read scripture.
So you've got somebody, you're highly suspicious of syphilis, enough that you send them for 3 FTAs. What's the likelihood that after 3, she's still negative? Because I was curious, like.
Did
after
you look it
1
up?
Yeah, I looked it up.
Well, wait a minute, you ordered them on test. This is secondary syphilis. You need to order the BDRL. Right?
No, I got RPR FDA. No, yeah.
RPRs.
Yeah.
But,
They've changed it now. It used to be RPR first, reflex
yeah, but
FTA.
this time you want the RPR.
I think,
Because this is secondary.
well, I
They
don't know. You
changed
got
it
the
now.
results
Now
back.
we do
They
FDA.
oftentimes will run both.
Yeah, they did the RPR.
Yeah.
They did both.
the
FDA.
And it was negative?
Yeah, negative.
Oh, okay.
So so after 1 test, there's a 26% chance approximately that it was a false negative and she could still have syphilis.
Okay.
After 2 tests,
26?
26.
High.
Yeah,
Wait, for RPR or for FTA?
for the FTA. So then after 2 tests, the likelihood that it's still wrong drops to around 10 to 12%. After 3 tests, though, the likelihood is 1.3% that it was a false negative. So it's still, I guess, if you see
Yeah.
enough syphilis and your suspicion is super high, I guess it's still theoretically possible.
I don't think the FDA turns right away. It's BDRL is the first thing to turn, and that's usually high positive and secondary. So that RPR is the equivalent, I think.
Yeah, I think so.
I'm surprised that's negative.
What about like the leptospirosis? Could this cause that?
I think this is something else. I'm not thinking.
Are you saying like it's false positive because of leptospirosis?
No, this causing that finding in the
I don't know what that's.
Leptospirosis causes.
eye.
So we had this differential. Number 1 on the differential was syphilis. That's basically knocked out based on testing. TB testing was also negative. So at least from this differential, that leaves us with ampi, serpiginous, and multifocal.
So in ampi, I always wondered, like, if you clinically thought it was that, because there's a concern for the CNS vasculitis with that. So like, do you send them to, even if they don't have a headache, send them to the ER and tell them to get like vessel imaging and
No,
maybe
it's just a
consider
headache. If
steroids?
there's a headache, you get nervous.
Okay.
But in the absence, ampi is these are all really rare. Ampi is very rare. In the absence of a headache, I would not sweat ampi. I had the report, there's a case report of a death with ampi, which actually came from this area. It was
Sorry, yeah.
They had a young woman die of ampi, of cerebral vasculitis, and I joined their practice in '92. I had a patient with ampi who had like almost nothing, and they put her right in the hospital. So, because they had that other patient die. But I think I think in the absence of a headache, it would be hard to not have a headache. In a headache, I don't know. Then I think you probably do need to get a little nervous.
Now, would they need to have kind of like a relentless headache since they were, I mean, I
I
had a
would
headache
think,
yesterday.
I know, I get it. That's why I do
You know,
not
I-
think this girl was worrisome, but I've seen, I mean, I see a lot of patients. I've seen like 2 or 3 ampies and 2 or 3 serpiginous. So they're not, it's way down on the list of commonalities.
Like, what's more likely, that 1.6% of
Right.
the triple false negative, or
Right.
the patient having a
Right,
disease
Right.
you've only seen?
yeah, they're
2
super
times?
rare. But,
Fair question. So you're gonna get a little bit more information here. So because infection had been ruled out, she was negative on syphilis ×3, TB was negative. She was treated with steroids. And then you're gonna get some more pictures, but of note, the right eye did get a little better. She went from count fingers to 2200. But now her left eye, which was treated, so I imagine, you know, it's not like she acutely worsened based on these next images from May. But she had been worsening, she got Kenalog on this 10 days prior to these images.
Okay, so actually the lesions look a little bit more large. They look a little bit bigger, maybe.
Maybe a little more diffuse, but a little bit less opaque, if I were to take you back to the very first one.
And the other thing to think about, are you now starting to see what you saw then on the ICG and FA? Because a lot of times the ICG and FA will show more, and then later. So it's hard to know.
And she didn't start like any new meds or anything prior to this.
Not that I'm aware of, at least.
No.
This one's maybe a little bit bigger,
Yeah, it's quite a bit bigger.
Yeah.
It's twice as big.
2 times.
Yeah, I
2.5?
think so, the area,
Three.
the area.
Did she get Kenalog in the left eye too?
She did. So these pictures are from the 20th. She had oral pred on the 6th, Kenalog in the left eye on the 10th, Kenalog in the right eye on the 13th. Sub-T knots.
What was when were the first pictures from?
I believe April.
Okay.
So there's about a month and a half in
Yeah, we're
between
testing.
these images.
I was hoping it was, I thought it was gonna be syphilis. We've seen so much syphilis.
Yeah.
I was saying, God, I can't believe it wasn't syphilis.
So here's another OCT of the right eye.
So I don't see as many exudates as before, but there's just a lot of outer retinal
Yeah.
damage and loss.
Outer retinal layers are pretty rough. Still the right eye.
The vertical one.
Yeah, there's nothing, we won't belabor the point on that. But now on the left eye, and this is different from when she first came in.
Yeah, this is getting a little fuzzy here.
Right.
So the outer retina is starting to change.
Right, so ISOS, inner and outer
And-
photoreceptor layers have kind of undergone the same change that we saw in the right eye. Just the other cut. So now we're into June. She's,
Oh,
yeah,
Yeah.
so
It's very pleasant, very good attitude. It matters, like, okay.
if anything, I thought this picture looked
Yeah.
right, the
Yeah.
most quiet of any of them.
Right.
Yeah.
Kind of those superior macular lesions are really hard to appreciate if you didn't know that they were there before. But then she still has these satellite areas. Yeah, so,
this,
yep. And then I
and
don't-
maybe that.
yeah, I think that one far superiorly is real. I don't think that's artifact.
Okay.
That looks semi-active.
And then, yeah, this was, the pigmented thing was there before, so I just see it here. Not there, I don't think that's real. So autofluorescence, so it's still very bright, so it's still very thick.
Yeah,
And I
that
would not-
autofluorescence is kind of I've seen a couple cases like this. That's kind of a typical serpiginous autofluorescence. It's really funny looking.
It almost looks like cartoony.
Yeah, it's very weird and it's hard to, I'm not sure.
Modigliani
I'm not sure what to make of it.
Modigliani uses a heavy outline around his news.
And again,
And so that has similar.
It's like a nude sea sponge.
and you can see those areas that we were talking about in the,
Oh, periphery.
yeah, out in the periphery, that they actually show up here. The exact same as the macular lesion.
Even like a cancer associated retinopathy that looks anything like this.
It doesn't trigger.
No, CAR doesn't do it. CAR does outer retinal atrophy. It's very typical. It's got a very scary autoimmune CAR and MAR, just everything looks normal, but the outer retina just starts to go.
And here's just another autofluorescence of the left eye. Again, I mean, aside from the size of the lesions, they look identical.
Would you do like a vitreous biopsy or some sort of tap to run some PCRs?
For viral,
Yeah,
I did not do that, and I always wondered, and maybe I'll talk about it.
Yeah.
Go ahead. If there's an association.
Right. So again, just more OCTs, really nothing new. Inner retina looks healthy, outer retina, ISOS photoreceptor layers have just been decimated. So now we're all the way into December, vision is still terrible. Was she getting periodic subtenons catalog throughout?
No,
this?
just the one, I find subtenons last about 6 months.
Okay,
So I don't think, unless there's some she finally switched off you. They were paying, she was a Humana patient. I see they're a weird patient. So she switched off Humana. But now she's back United.
that looks good. And new, maybe.
maybe.
This looks atrophic now.
Yeah.
Maybe it's like a little spot and then the acute stuff is gone.
So maybe this is serpiginous.
No, it is. It is, and it's devastating.
So a couple of things that help distinguish, because we were talking about ampi versus serpiginous early on. Ampi, to my understanding, would typically have improved. She wouldn't have
That's the
stayed.
biggest thing. My,
Yeah.
my finding is that it's ampi. I told her it's gonna be ampi or serpiginous, but I can tell. And I said, well, no, if you get better, it was ampi. Because the ampi patients, it looks like someone like ripped apart their macula in their 2030.
Well,
It's
not
shocking.
acutely, that's,
No, after when they heal. It's
yeah, but
remarkable.
acutely, they can be down.
Right,
Right.
right, the same
2400.
decrease, right,
Yeah.
but they should have bounced back.
And I used to have, I don't know if I might have lost it, but I had this beautiful case where on the OCT, you could see the layers coming back.
Right,
So
yeah, which is interesting. It's totally different. So go ahead.
So they think it's likely immunogenic. However, Sabrina, what you were getting at in terms of a biopsy, there are some papers that speculate there could be an association with HSV and there could be an association with a mycobacterium, but that has never been fleshed out, likely because of how rare it is. You're never going to get enough samples to prove any kind of association. In terms of subtypes, this was on the differential screen, and I have some pictures coming up. So this was likely more of an ampiginous chorioretinopathy. Might also see it referred to as a relentless placoid choroiditis. I like that naming. It's more descriptive. It makes you understand just how bad it is. And some places talk about this kind of being on a spectrum. So, you know, because early on, it only looked like she had macular involvement. And then it looked like she had some satellite lesions out in the periphery. And then we'll talk about kind of a more classical serpiginous where it's just in the peripapillary region, which she actually really didn't have affected. Her peripapillary region was pretty intact throughout the course in both eyes. Couple of things that are strange about this. Not only is it rare, it's typically male greater than female. And the demographic, it's younger people, at least based on literature. And again, I don't know how much you can trust that because of how rare it is, but she's well outside of the typical age range for this.
Well, ampi is usually younger, right?
Correct. Yeah, they're both younger.
And this is, yeah,
They're both younger.
well, I think the ones I've seen, there aren't many, were older.
They're a little low.
Okay.
Serpiginous, ampi's more like 30, the serpiginous more like 50.
This, yeah, that what I found said 40 to 50. So like what was done in her workup, you have to rule out infectious causes. So you have to rule out syphilis and TB because, and the biggest thing for that is you're going to treat these people with steroids, or even potentially, I saw some reports of treating these people with systemic immunologics.
Right.
And you can't put them on that if there's any concern that it could still be syphilis or TB. So on FA, again, a lot of these things we already talked about: early hypo, late leakage, late hyper. ICG was hypo throughout, which was consistent for her. And then on the autofluorescence, she had these. If we go back to it, they end up with like this dark pigmented border all the way around, which was true of both the macular and those extramacular satellite lesions. And then they basically become dark and uniformly hypo-autofluorescent towards the end. And then here's just some pictures. So top left is kind of a more classic serpiginous. It's in that peripapillary region. And then bottom left is a macular variant. And then middle was actually a picture of a relentless, so ampiginous. And again, she kind of had a mix of the two. The left eye stayed more consistent, looking like that macular serpiginous. Whereas the right eye was kind of a mix where she developed these satellite lesions, and then the bottom right is showing another case of ampiginous, where they end up with not only a nidus in the macula, but these extra macular or paracentral.
The term serpiginous means snake-like.
Right.
And classically, what happens is you get an initial lesion, and then you
It
get.
snakes around.
No, and then you get a recurrence, an acute white lesion on the old pigmented lesion. And then that fades, so you get, and then another one occurs, and it keeps on doing this,
Kind of connected
and you
up.
get a snake-like pattern.
Yeah.
But this pattern, I think, is at least as common. It is
Macular.
where you get these scattered spots keep coming back, and it is, you know, it is a relentless disease. And,
Yeah.
and it's progressive, but go ahead about treatments.
Yeah, so like Dr. Pavin's saying, that bottom point there speaks to that. A quarter of these patients never get better than 2,200. And that's in spite of treatment.
Oh,
These are
but
people that
acutely,
are treated.
Treatment's a waste of time. I think. So I think Jim Polk out in Iowa, did you come across his papers?
Mm-mm.
Yeah, he basically said you gotta immunosuppress these
Systemically.
to prevent the recurrence,
Uh-huh.
and it works. He had, I think his
Yeah,
paper.
if she had central vision, if like that one spot in the left eye, it's
Yeah.
stopped,
Was,
I probably would have her on lifetime immunosuppressants. But in the absence of central vision.
Yeah, and I don't remember, I never did that, but he did show that. He recently retired. We went through training together, that's why I know about it.
Okay. And then obviously, so the mainstay of treatment here is either gonna be steroids, you can, and there's papers on this, you can do subtenons, some talked about doing intravitreal. But like Dr. Pavin's saying, in terms of long-term systemic, either anti-metabolites or anti-TNF agents. And then the only change to that would be if they develop CMV. Again, not a huge collection of data for this, but it's somewhere between 30 to 35% of these patients develop CMV that then requires anti-VEGFs. Otherwise, that suppressing the immune system is going to be the mainstay. That's all I have.
That was very good. That was a long one.